Hi everyone and welcome to the last part of the rapid revision or rapid run, last run towards your exam, which is tomorrow. First and foremost, before I begin, wishing you all the very best for the paper. Have full confidence in your preparation. You guys are definitely going to rock the exam. So waiting for all your happy responses tomorrow and wishing you all the very best for the exam. So let's begin without any delay. Let's start with question number 1. It's a mixed bag, as all of you know, and question number 1 says elevation of IgM is associated with. It's going to be very rapid. I'm not going to include anything in depth, only what is important for the exam. So elevation of IgM, whenever I say the word IgM, we are dealing with macroglobulinemia. So please remember, elevation of IgM is seen in Waldenstrom's macroglobulinemia. Let me tell you, the most common plasma cell tumor that all of you consider, which is multiple myeloma. The multiple myeloma shows you an elevation of most commonly IgG. So IgM is for Waldenstrom's macroglobulinemia. I hope that is clear with everyone. Number 1 question. Number 2, which of these is a central regulator of iron metabolism? I hope everyone remembers it is hepcidin. So let's study hepcidin. What are the classical questions you're going to get? Number 1, it's a master regulator, or you can also call it a central regulator of the iron metabolism. 1. Second, please remember, they ask you the source of hepcidin. So you know that source of hepcidin is going to come from, hep means hepatic, means it's going to come from the liver. Next, they ask you question, what is the function? So what is the function? The function is in matlab inhibition. It inhibits iron metabolism. It inhibits iron absorption. Okay, so these are the classical questions of hepcidin. How does it inhibit iron absorption? It inhibits iron absorption by blocking an enzyme, that is ferroportin. It inhibits iron absorption by blocking a port, that is ferroportin. Okay, so that is the port which brings iron inside. So quick question revision. Hepcidin is a master regulator of the iron metabolism. It comes from the liver and it inhibits iron absorption via blocking ferroportin. Hepcidin inhibits ferroportin. Okay, moving on to question number 3. All of the following cause microcytic hypochromic anemia except. First, you should know the mnemonic for microcytic hypochromic anemia, and that is Sita. So what is it? It is number 1, sideroblastic anemia. I hope you also know that sideroblastic anemia, one of the causes of sideroblastic anemia is lead poisoning. I for iron deficiency anemia, T for thalassemia, and A for anemia of chronic disease. All of these are microcytic hypochromic. So yes, iron deficiency, thalassemia, lead poisoning, they are microcytic hypochromic. The answer to this question is Fanconi anemia. This is a type of an aplastic anemia. Fanconi anemia is a type of an aplastic anemia which is normocytic normochromic. So yes, we are going very rapid. I hope everyone is keeping in sync with it, because in exam coming up tomorrow, we have to waste minimum time. Lymphoma which presents with cutaneous lesions. There's a classical single lymphoma which presents with cutaneous lesions, and that is mycosis fungoides. So let me tell you, mycosis fungoides obviously will show you skin lesions, and in the skin on microscopic examination, it shows you something known as Potrier's microabscess. The same thing should remind you of another abscess. In which disease do you see Munro's microabscess? So please remember, Munro's microabscess is seen in psoriasis. Where do you see Potrier's microabscess? You see it in mycosis fungoides. I hope that's clear. It's a lymphoma, to be very precise. It's a TNHL, T type of non-Hodgkin's lymphoma, which involves the skin. Moving on. College girl appearance or garden party appearance of leukocytes are seen in. Please remember, this is seen in CML. So in CML, we see the college girl or the garden party appearance. That's the answer. Whereas in CLL, we see the convent school appearance. we see the convent school appearance. So yes, convent school appearance in CLL, because all the cells look the same. They are lymphocytes, all of them look the same. CML shows you variety of cells. So college girl or garden party appearance. Let me tell you, or let me ask you, which is the cell that you see in CLL which is very, very important. I hope everyone remembers that in CLL we see the smudge cells. Smudge cells are also known as the basket cells, or they are also known as the parachute cells. So yes, all of these are other names and they are very, very important. Okay, moving on, one of the most expected questions, mention the stain used below. So first you should be able to identify what this image is. All of these are red blood cells because they don't have a nucleus. And what are these cells which have this blue material inside it? This is a reticulocyte. So when I'm talking about a reticulocyte, please remember it is stained using supravital stains. It is stained using a supravital stain, okay? And examples of supravital stain are new methylene blue and brilliant cressyl blue. All the blue stains, okay? New methylene blue and brilliant cressyl blue. That is why what appearance or what granular content are you seeing? What color? You're getting the blue color because new methylene blue, brilliant cressyl blue. Which is the best one? It's new methylene blue. What about the other questions given over here? Other options. I hope Prussian blue and pearl stain, everyone knows it's the same thing. It's the same thing, special stain that we use for iron. I hope oil redo, everyone remembers, is the special stain that we use for fat. Moving on to the next question, an all-time favorite image with the examiner. There's a 5-year-old child with osteolytic lesions in the scalp. Biopsy shows sheets of cells showing nuclear grooving, and the following electron microscopic picture gives you tennis racket appearance. Well, examiner's been good to you. He's told you everything. See, this is electron microscopy showing you the tennis racket appearance. And now they've asked you which is the special stain, immunohistochemical marker. So what disease is this? This is Langerhans cell histiocytosis. What is the gold standard for the diagnosis of Langerhans cell histiocytosis? Gold standard is exactly written over here. Gold standard is electron microscopy showing you the tennis racket appearance of the Burbeck granules that you see over here. If you have to do any immunohistochemical marker, then CD1A is one of the most important immunohistochemical markers that you'll use. Langerhans cell histiocytosis. Please remember, LCH mutation that you see in Langerhans cell histiocytosis is BRAF mutation. It is BRAF mutation. Let me tell you, when you're talking about BRAF mutation, there are many tumors, but two that you have to know. One is in front of you, Langerhans cell histiocytosis. If you read it in the opposite direction, HCL. Hairy cell leukemia. So LCH, Langerhans cell histiocytosis, and HCL, hairy cell leukemia, both of them show you BRAF mutation. Moving on to the next question, the very much expected question, blood banking. Ideal storage temperature range for whole blood. So first let me tell you, whenever you're dealing with whole blood or anything to do with red blood cells, whole blood or packed red blood cells, you are going to keep it at 2 to 6 degrees Celsius in a refrigerator. When you're dealing with platelets, that is platelet rich plasma, you are going to keep it at 20 to 24 degrees Celsius in a machine known as an agitator. The machine plates should always be moving. The platelet bags should always be moving. Otherwise, the platelets will start aggregating and you don't want that. So all the time it should be moving. 20 to 24 degrees Celsius. Moving on to the fresh frozen plasma. Plasma, obviously frozen plasma. So you have to keep it at a frozen temperature of less than minus 18 degrees Celsius. So yes, what was your question out here? Ideal storage temperature for whole blood is 2 to 6 degrees Celsius. For platelet rich plasma, 20 to 24 degree, and for FFP it is less than minus 18. With this, can we also finish off their shelf life? So let me tell you, shelf life of fresh frozen plasma is 1 year. Shelf life of platelet rich plasma is 5 days, and whole blood or anything that has RBCs depends on the anticoagulant that you've used. If you have used CPDA anticoagulant or if you have used Sagum anticoagulant, the days will vary. For CPDA, you can store it for 35 days, and for Sagum, with Sagum, you can store it for 42 days. Which turns out to be better? Obviously Sagum, because it helps you store the blood for 42 days. But it's very expensive. So what is most commonly being used in the blood banks is a CPDA. Okay, so CPDA 35 days, SAGM 42 days. Better one is obviously SAGM, but very expensive. So CPDA is what is being most frequently used. Platelets 5 days, FFP 1 year. Moving on. Well, a pretty much expected question in Path and Micro. There's a 20-year-old female presents with a 5-day history of headache, sore throat and low-grade fever. In today's scenario, you might have started, although fever is not low grade in this, but in today's scenario, you might have started thinking of COVID. But read further. On examination, there is bilateral enlarged lymph nodes and tonsillitis. Peripheral smear examination shows an elevated total leukocyte count of 14,000. Let me tell you, normal total leukocyte count is 4K to 11K. 4,000 to 11,000 is the normal WBC count, so here it's more, it's 14,000. With the presence of cells of showing you ballerina skirt appearance, that's your classical hint. Ballerina skirt appearance is something that you see in infectious mononucleosis. Ballerina skirt appearance is something that you see in infectious mononucleosis, basically something that you see with Epstein-Barr virus. Which of the following statement is true? Monospot test is done, ASO titer, anti-DNase B antibody or tennis racket appearance. Let's go in the opposite direction. Tennis racket appearance, though it can't be, because I just told you tennis racket appearance is seen in LCH. We just saw it. Anti-DNase B and ASO titers are something that you see with streptococcal infection. Well, yes, you can see sore throat and all with streptococcal infection, but will you see the ballerina skirt appearance cytoplasm? No. So that is something you see with Epstein-Barr virus, and the test that you do for Epstein-Barr virus testing is the monospot test. So what is your answer out here? Your answer out here is the monospot test. I hope everyone is clear. Catch point was ballerina skirt appearance. Moving on, guys, to the next question. Which is the thyroid cancer showing amyloid deposition? So we have classical 4 thyroid cancers in front of us. All of you know that amyloid deposition is seen in medullary carcinoma thyroid. Which type of amyloid is seen deposited over here? ACAL. A means amyloid and cal means calcitonin. Cal means calcitonin. Basically, you should know that calcitonin is the tumor marker for medullary carcinoma thyroid. It is the tumor marker for medullary carcinoma thyroid, and when it increases, it deposits as amyloid. Okay, which out of these is going to have the worst prognosis? Anaplastic carcinoma has the worst prognosis for the patient. Which out of these has the best or the excellent prognosis? Papillary carcinoma has the excellent prognosis. In the part 2 session, I had taught you which is the classical nuclear appearance that you see for papillary carcinoma thyroid. We see the orphan Annie I nucleus. And any type of calcification that you see in papillary carcinoma thyroid, we see the Samoma bodies, right? Okay, so orphan Annie I nucleus, Samoma bodies, done. Amyloid, medullary carcinoma. Moving on to the next one, the best and the most favorite question of every examiner, Verrucke bodies. Verrucke bodies are seen in, everyone knows, schwannoma. So let me tell you one question about every option I want to tell you, and that is what is important. Verrucke bodies, schwannoma. Rhabdomyosarcoma question that you get is that it shows you the cambium layer. Retinoblastoma shows you a rosette. Which rosette? Flexner-Winter-Steiner rosette. And which are the bodies that you see in yolk sac tumor? Taught you in the previous session only. In yolk sac, we see the presence of Schiller-Duval bodies. Also known as the glomeruloid bodies. Yes, are we clear with this? So this was one-liner question of each. Quick revision: Verrucke bodies, schwannoma; rhabdomyosarcoma, cambium layer; retinoblastoma, Flexner-Winter-Steiner rosette; yolk sac tumor, Schiller-Duval or glomeruloid bodies. Let's move on to the next one. Oil red O positivity is seen in which type of ALL, if at all, or none? Let me tell you, ALL, acute lymphoblastic leukemia, is L1, L2, L3. L1 is the most common and has a good prognosis. L3 is the least common and has a bad prognosis. The one which shows oil red O positivity is L3. The one that shows oil red O positivity is L3. So remember, L1 is most common, and thankfully God has made it as the good prognosis. It's most common and good prognosis. L3 is least common and thankfully worst prognosis, but thankfully it's least common, okay? And oil red O positivity also comes in ALL L3. Coming to the next question. Okay, COVID-19 was declared as a pandemic by WHO on which date? COVID-19 was declared as a pandemic by WHO on March 11th. Let me tell you, on Feb 11th, the terminology. I'm sorry, yes, on Feb 11th, the term COVID-19 was kept. The term COVID-19 was kept on Feb 11th. It was finally labeled as COVID-19, but March 11th, it was declared as a pandemic by WHO, March 11th. Moving on, next one. The granuloma given below is seen in sarcoidosis, cat scratch disease, lymphogranuloma venereum, or both B and C. So which granuloma is this? The granuloma which looks like a star. The granuloma which looks like a star is a stellate granuloma. And stellate granulomas are seen in both cat scratch disease as well as lymphogranuloma venereum, both B and C. Let's move on to the next question, a very much expected question in the exam, be it medicine or be it path. A 35-year-old male presents with malabsorption. Duodenal biopsy image shows lamina propria filled with foamy macrophages, which is the special stain that you would use to confirm the diagnosis. So guys, this is a classical case of Whipple's disease. Yes. So let me tell you two very characteristic questions about Whipple's disease. Whipple's disease is a type of a malabsorption. Whipple's disease is caused by the organism Tropherema whipplei. It is caused by the organism Tropherema whipplei. So simple, Whipple's disease is by Whippley. How do you do the diagnosis? To do the diagnosis, the gold standard is biopsy. You are going to take a biopsy, and in a biopsy, you see PAS positive macrophages in the lamina propria. You see PAS positive macrophages in the lamina propria. So here you are seeing these PAS positive macrophages. Everyone remembers the basic mnemonic? Yes, P for P. PAS gives which color? Quick. PAS gives a pink color. So here you see a cluster of cells which have come out pink. Why? Because I've stained them with PAS. Learn this line as it is. PAS positive macrophages in the lamina propria in a biopsy is the gold standard for Whipple's disease. It's a malabsorption. I hope it is clear with everyone. Coming on to the next question. The following bodies are seen post splenectomy. Easy one. You guys have learned much more than this. This is very easy. Post splenectomy, we see Howell-Jolly bodies. Can everyone see these bluish color bodies that are there in the RBCs? This is Howell-Jolly bodies. Two questions you get on it. Howell-Jolly bodies are seen in megallanemia, number 1. Howell-Jolly bodies are seen post splenectomy, number 2. So here the history given to you was post splenectomy. And next question they will ask you, what is the composition of the Howell-Jolly bodies? They are nuclear remnants. Howell-Jolly bodies are nuclear remnants. Okay, I hope it is clear. Never confuse them with Heinz bodies. Heinz bodies are the ones that you see in G6PD deficiency. And Heinz bodies are nothing but denatured hemoglobin. They are nothing to do with nuclear material. They are denatured hemoglobin. I hope that is clear with everyone. Moving on to the next one. Which antibodies are seen in the condition showing this classical image? And this image, though, everyone knows. We are dealing with a case of a strawberry tongue, and if we are dealing with strawberry tongue, then which vasculitis are we dealing with? It is a case of Kawasaki disease. It is a case of Kawasaki disease. So now you have to tell me which antibodies are seen in a case of Kawasaki disease. Anti-endothelial cell antibodies. Anti-endothelial cell antibodies are seen in Kawasaki disease. Yes? Okay. Talking about another vasculitis. A patient presents with respiratory symptoms. And that is cough, hemoptysis, and glomerulonephritis. The following antibodies are most likely to be increased. So respiratory symptoms, lung is involved with hemoptysis, and the kidney is also involved. So there is involvement of the lung also, there is involvement of the kidney also. So which disease have you started thinking of? When you're talking about lung and kidney, there are two diseases that should come to your mind. One is Goodpasture syndrome. okay, and the other is Wegener's granulomatosis. One is good pasture syndrome, other is Wegener's granulomatosis. Now in good pasture only lung and kidney are involved, and which antibodies? Anti-glomerular basement membrane antibodies. Are these there in the option? No, I don't have anti-glomerular basement membrane. So this is not good pasture. That is how you attempt questions, okay? Then you say, acha, the other option that I have is Wegener's. In Wegener's, the antibody that I see is most commonly I see PR3 ANCA, or also known as C ANCA. So yes, PR3 ANCA is there in the options, also known as C ANCA. Let me tell you, Wegener's can show you both these ANCAs. PR3 ANCA and MPO ANCA both can be seen, but you have to select one best answer. So more commonly it shows you PR3 ANCA. Is the approach to the question clear? Lung and kidney involvement are seen in good pasture and Wegener's, but good pasture shows you anti-glomerular basement membrane antibodies. That was not an option given to me only. I was given PR3 ANCA positivity, if that is there, so I'll go in for PR3. Moving on, coming to the next one, the marker of cellular autophagy, simple one-liner. The marker of cellular autophagy is LC3. LC3 is the marker and ATGS1 is the gene, okay? So don't get confused. Here they asked you marker is LC3, ATGS1 is the gene. If they ask you marker of apoptosis, it is annexin 5. It is annexin 5. One more question I want to tell you. There are two annexins that all of you have to remember in pathology. Annexin 5 is the marker of apoptosis, whereas annexin A1 is the marker of hairy cell leukemia. Annexin A1 is the marker of hairy cell leukemia. So I hope this revision is helping you correlate all different chapters and similar sounding things that you have studied. Okay, moving on. Which of the following does not have a double-stranded DNA genome? Does not have a double-stranded DNA. So what is the rule? All the DNA viruses have double-stranded DNA virus except one of them, that is parvovirus, which is single-stranded DNA. So how will you remember? Vo has one, Vo has single-stranded DNA, rest all DNA viruses are going to have double-stranded. I hope everyone is clear with this question. Okay, moving on. Simple one-liner, but you have to know. MYC2 is a marker of which of the following bone lesions? MYC2 is a marker of Ewing's sarcoma. MYC2 is a marker of Ewing's sarcoma. Remember, if MYC2 is written or CD99 is written, it's the same thing. Remember, they are a marker of Ewing's sarcoma. If they ask you the radiological finding of Ewing's sarcoma, I hope everyone remembers the onion skin reaction. Onion skinning is seen radiologically for Ewing's sarcoma. Moving on to the next question. Asbestosis is associated with all of the following except mesothelioma, progression of lesion even after stopping exposure, nodules in the upper lobe, and asbestos body in the sputum. Let me just tell you one mnemonic and then all of you will automatically learn it yourself. Instead of calling it asbestosis, I always call it bastosis. Why? Because this involves the lower lobe. All other pneumoconiosis, like if you say silicosis and so on, all other pneumoconiosis involve the upper lobe, but asbestosis is base. So base involves the lower lobe. So was this statement correct? No, that's the answer. Nodules are not seen in the upper lobe, they're seen in the lower lobe. Others are right. Asbestosis is associated with mesothelioma. Yes. Progression will happen even after stopping the exposure. Yes. Asbestos bodies are seen in the sputum. Can you recall what is the shape of the asbestos body? Yes, everyone remembers shape of asbestos body is dumbbell shaped. It is dumbbell shaped. Okay, having read that, I'm going to now talk about lung tumor, and the most important table that you have in lung tumor is the paraneoplastic syndromes. So first I'll teach you and then we are going to go in for a discussion of the question. Okay, so which is the paraneoplastic syndrome that you see with squamous cell carcinoma? It is hypercalcemia. Little bit of mugging up, but you have to do it. Squamous cell carcinoma, hypercalcemia. What is the paraneoplastic syndrome for adenocarcinoma, it is migratory thrombophlebitis, Trousseau's phenomena. Do you remember? Trousseau's phenomena, migratory thrombophlebitis. Small cell carcinoma is SIADH, Cushing's and Lambert-Eaton. So can I say which is the cancer associated with maximum paraneoplastic syndromes? Small cell carcinoma. It has SIADH, Cushing's and Lambert-Eaton, and for large cell carcinoma it's just one, gynecomastia. Everyone's learnt it. Can I show you one table? Can you match these for me so that I know that you are very confident? Hypercalcemia, which tumor should I mark it with? Hypercalcemia is seen in squamous cell carcinoma, yes. Migratory thrombophlebitis, it is seen in adenocarcinoma. Okay, SIADH, small cell. What is the other name for small cell? Oat cell cancer. So SIADH is seen with oat cell cancer and gynecomastia is seen with large cell cancer. I hope it is clear with everyone. Moving on, coming on to the next one. Starry sky appearance in a histological slide is due to, first tell me, starry sky appearance reminds you of what? So there are two starry sky appearances that you have in pathology. One is what you see in Burkitt's lymphoma. Okay, the Burkitt's lymphoma starry sky appearance you are going to see on a pink and blue slide, HNE slide, okay. The other one is what you see in post streptococcal glomerulonephritis, PSGN, but in that you see it on an immunofluorescence. So they've asked you the mutations, the translocations. Now PSGN, post streptococcal glomerulonephritis, is an infective etiology. It is not showing me translocations. Burkitt's lymphoma shows me translocations. Which translocations? B for Burkitt and 8. B for Burkitt and 8. So please remember, all the 8 related translocations are seen. All the 8 related. So remember, 814, 28, 822. Pick up the translocation from here now. Automatically you will pick up that it is translocation 28. It is translocation 28. I see two very important translocations in the other options. Guys, translocation 922. Remember Philadelphia chromosome, CML. Yes. And translocation 1517, with which we ended part 2 session. I told you translocation 1517 is seen with which AML? AML M3. Can you recall part 2, last question I taught you, which is the cell that you see in AML M3? Faggot cells, lots of OR rods. Remember that last question we did? Okay, moving on, coming on to the next one. All of the following are true about a bacteriophage except it is a bacteria, it helps in transduction, it imparts toxigenicity by lysogenic conversion, it can cause drug resistance. Yes, so which is these is false. Guys, yes, it helps in genetic transfer, transduction, that is its function. By genetic transfer, it can even transfer toxigenic strains. Yes, it can even cause drug resistance, but it is not a bacteria. Bacteriophage comes under the category of a DNA virus. Bacteriophage is a DNA virus. Remember the tadpole shape morphology that you study? It is a DNA virus, okay? It is not a bacteria. Okay, moving on, immunoglobulin found in bronchial secretion, or for that matter any secretion. The secretory antibody is IgA. So if I say IgA has two names, one it is known as mucosal antibody and the other it is known as secretory antibody. So when I say which is the antibody that you find in the intestinal mucosa, it is IgA. Which is the antibody that you find in the body secretions, it is going to be IgA. I hope everyone is clear with this question. Let's move forward, moving on. Okay, so I hope you are able to understand this rapid revision, and I'm not too rapid, but you have an exam tomorrow, so we have to be quick. Okay, the pretty much expected question, the recent most, CRISPR technology. What is the function of CRISPR? Bacterial genome editing to protect against viral infections, bacterial genome editing to protect against human immunity, mechanism for viral immunity, or genetic reactivation. Remember, this is bacterial genome editing to protect against viral infections. What is CRISPR? You have to know the full form. So please remember, CRISPR stands for clustered, please know the full form, clustered regularly, interspaced, I've got it written for you, clustered, regularly, interspaced, short palindromic sequences. Please remember, clustered, regularly, interspaced, short palindromic repeats. Okay, so this is a CRISPR. Can you see these pink color? These are some palindromic repeats. Okay, these are some palindromic repeats. In between them, do you see spacers? So there are spaces, they are interspaced. There's a cluster and a space, a cluster and a space. So clustered, regularly interspaced, short palindromic repeats, that is a CRISPR, and we club it with a molecule called Cas9. The name of the full system is the CRISPR-Cas9 system. What is it? I have to tell you in exactly 2 lines, okay? It was identified because, you know, there were bacteria, and those bacteria said that, you know, viruses are trying to infect us. Bacteria said viruses are coming and trying to infect us, so we should also have an immunity that we can fight against viruses. So they said we will have an immune system to protect ourselves against viral infections. We will have some genetic technique that we can protect ourselves against viral infections. That is how CRISPR started. So it is a bacterial genome editing mechanism to protect, bacteria need to protect themselves from viruses. We are using CRISPR-Cas9 as one of the techniques for human gene editing. We are using it for human gene editing. So yes, for genetic editing, we are using CRISPR-Cas9. Please be aware of it. Next, I'm going to show you 2-3 pictures. I hope everyone is very well versed with this picture. What is this? This is an autoclave. This is an autoclave. So yes, what temperature do you use it on? 121 degrees Celsius for 15 minutes for 15 pounds square inch. Okay, 121, 15 minutes. But for prions, 134 degrees Celsius for 1.5 hours. 134 degrees Celsius for 1.5 hours. This is an autoclave, please remember. Okay, let's quickly see some inclusions. Everyone remembers the very famous owl eye inclusions. Everyone remembers the owl eye inclusions that you see in CMV. I hope you remember owl eye you see in cytomegalovirus, and you also see in the Reed-Sternberg cells. Yes, you also see in the Reed-Sternberg cells. So very characteristic. The next one and the expected one, the one which shows you these Warthin-Finkelde giant cells. So if I can zoom into this, can you appreciate the Warthin-Finkelde giant cell? Can you see every nucleus has a pink color dot? Yes, every nucleus has a pink color dot. So can I say it is going to show me both intranuclear and intracytoplasmic inclusions? It shows both intranuclear and intracytoplasmic inclusions. That is the Warthin-Finkelde giant cell of measles. Warthin-Finkelde giant cell that you see in measles. Last one. This is a cup-shaped lesion. It's a cup-shaped lesion. I'll write it again for you. Cup-shaped lesion. And please remember, cup-shaped lesion is seen in molluscum. It is seen in molluscum contagiosum. And what you see in molluscum are HP bodies. So again, if I may zoom into this, can you all appreciate these pinkish color bodies out here everywhere? Can everyone appreciate this? This is the molluscum contagiosum bodies, or the HP bodies. Please remember, these are known as HP bodies. Are we clear with these inclusions? So what all do we have? We have number 1, we have the owl eye inclusions. Number 2, we have Warthin-Finkelde of measles, and number 3, we have the HP bodies of molluscum. Let's proceed forward. Now let's go on to another question. Pilot wheel appearance of multiple budding is seen with which yeast cells? So please remember, pilot wheel, P for P, pilot wheel appearance is seen in paracoccidioidomycosis. Let me tell you, paracoccidioidomycosis can either show you a pilot wheel or they can show you the Mickey Mouse appearance. These are two very characteristic questions. Mickey Mouse appearance. Okay. Blastomyces, B for B, shows you figure of 8. Okay. So B looks like 8. It shows you figure of 8 budding. Figure of 8 budding. They will ask you, what about sporothrix? What about sporothrix? So please remember, sporothrix is going to show you the asteroid bodies. Sporothrix shows you asteroid bodies, and Candida, everyone knows Candida shows you something which I'm going to show you in the next slide. Germ test tube or germ tube test is positive in which Candida? Candida albicans. Let me tell you, germ tube test is positive in it actually helps you differentiate Candida albicans from the other Candida species. So it is positive in Candida albicans. I hope it is clear. Paracoccidioidomycosis, pilot wheel or Mickey Mouse. B for 8, blastomyces, figure of 8. Candida shows you germ tube, and sporothrix shows you asteroid bodies. Moving on to the next one, non-bile stained eggs are. I hope everyone remembers the mnemonic for non-bile stained eggs. What was the mnemonic? Neha. Yes, the mnemonic for non-bile stained eggs is Neha. So what is Neha? N for, what is written over here? Nectar americanus. E for enterobius. H for Hymenopsis nana, and A for ankylostoma. Can everyone see this image first? Non-bile stained eggs are Neha. Please remember. So what all is it? Nectar americanus, enterobius, Hymen H nana, and ankylostoma. So obviously, which was the one that was wrong over there? So the one that was wrong over there was strongyloids. That is not a non-bile stained egg. I hope it is clear. Okay, Dane particle is seen in. So well, Dane particle is nothing but the other name for hepatitis B. It is the other name for hepatitis B. Okay guys, moving on. Now what I have to teach all of you is the serology of hepatitis B. So we are left with three things that I have to teach you. Number one, the serology of this hepatitis B. Number two, we have to revise all the vacutainers that are there for us. Number three, we have to revise all the parasitology eggs that they will ask you. And one more thing, we have to revise images of blood bank. So yes, these 3-4 things are lined up, which are very, very high yielding. So let's begin with this. When I talk about the serology of hepatitis B, that's the graph that all of you are very well aware of. Let's decode it, give you one mnemonic which is going to make your life very simpler. So which is the first one to appear? And that is HBsAg. It is HBsAg. Okay, so the first one which indicates your onset is HBsAg. So here it is. Here it has started. HBsAg, number one. After HBsAg, please remember the next one to come in is HBe. HBe is also known as the pre-core. HBe is also known as pre-core antigen. So it appears very shortly after HBs. See, first HBs came and then shortly after it HBe has come. What is it indicating? It always indicates either active infection or very high infectivity. It tells you very high infectivity, it tells you very active infection. So can I say that when HBe antigen levels decline, and antibody starts, anti-HBe antibody starts, can I say that is indicative of the infectivity going down? Yes. So which was the first one which indicates onset? It is HBsAg. Which is the one that indicates high infectivity? It is going to be the HBe, and when HBe antigen levels go down and antibody comes up, it is decrease in infectivity. Okay, now let's talk about which antigen are we left with. See, hepatitis B has three antigens. One is the surface antigen, HBsAg. One is known as the pre-core antigen, that is HBeAg, and one is known as the core antigen, that is HBcAg. HBsAg, other name for HBsAg, guys, quick, other name for HBsAg, you know it. Australia antigen, very good. Australia antigen. So HBsAg is you've studied. HBeAg you've studied. HBcAg is in the core. It does not come out in the blood. So you will never do testing of HBcAg. Golden rule, learn it, mug it up for a lifetime. HBcAg antigen testing in hepatitis B is not done. It's in the core. It will not come out in the blood. But it's there in your body now, so your body is going to react to it. Antibody against it will be produced. Antigen in the blood is not coming, but your body is reacting to it. Antibody will be produced. Antibodies will be IgM type and IgG type. Earlier is IgM, so can you see over here this red color line that has started? IgM type of anti-HBc. IgM type, and then the green line is showing you the total, because total will include M and G, right? M and G. So can I say that IgM antibody comes first, and that is your marker of the window period question of your previous year. What is the marker of your window period? It is IgM type of anti-HBc. I hope it is clear to each one of you. And once this declines, finally comes the anti-HBs. So can I now give you one very simple rule? Can we say that for acute hepatitis, will HBs, which was the first to rise, HBs, surface antigen, that will be there? Yes. Then the infectivity one, HBe antigen, that will be there? Yes. Will your marker of the window period be there? Yes, IgM type of anti-HBC, IgM type. So can I say surface antigen will be there, then the IgM type of HBC will be there, HBE antigen will be there. That is what is going to tell you about acute hepatitis. Versus chronic hepatitis mein, the same thing, surface antigen will be there, HBE antigen will be there with if it is high infectivity, but instead of IgM, can I say IgG type of anti-HBC will be there? Will everyone remember for acute hepatitis, will you remember SEMA, that there is going to be surface antigen, there is going to be E antigen, there's IgM type of anti-HBC, and that is what indicates acute hepatitis. Are we clear with this? And if I say no, the patient is in window period, which is the marker of the window period? So you know the marker of the window period is IgM type of anti-HBC. I hope this is clear with each one of you. Yes, what are we left with? We now have to go in for a revision of all the color coding of the vacutainers. Let's begin. Number 1, which is the vacutainer which has a red or a yellow cap? They are used for the same thing, okay? They are used for the same thing, only their constituents are different. When I say that I have a red cap vacutainer, that's a plain vial, and when I say a yellow cap, that is also the same thing, but it has a gel at the bottom. See, both of them are the ones in which you want the blood to clot. You want it to clot. So obviously it will not have any anticoagulant. It will have clot activators. You want the blood to clot. But this yellow cap, additionally, in the bottom it has a gel. This gel is going to make that clotting process faster. Okay, so this gel will help in clotting process. What are they used for? Whenever you want to do any serum studies like hormone studies and enzyme studies, these are the ones that you're going to use. I hope that is clear. Yellow and red. Next, the bread and butter of pathology, the lavender vial. Why? Because it has EDTA, and this is what you want to do all your complete blood count, peripheral smear examination, all of these you do with the lavender vial. Apart from that, you also measure ESR of the Wintrob's method by the lavender vial. So CBC, PS and ESR in Wintrob's method. Moving on, how do you then measure the ESR by Westergren's method? The Westergren's method, ESR is measured using the light blue or the citrate vial. So ESR by Westergren method, and all the coag studies, PT, APTT, all these studies are done in this citrate blue cap vial. So how many methods of ESR have we done? I told you the Wintrob's method is going to use the lavender vial. Then I'm telling you the Westergren's method is going to use the blue cap vial. But what if you're doing it in a machine? If you're doing automated ESR, then automated ESR gets you the black cap vial. It gets you the black cap vial, and that is the citrate vial. I hope that is clear with everyone. Moving on. Now, what was the vial with EDTA? Lavender. EDTA was lavender. If I keep the same EDTA, but I just change the cap to a pink. I keep the same EDTA and I change the cap to a pink. It is the vial that you use in blood banking. So you know you want your blood bank samples to shine out. It's a very sensitive area of your department. So the blood banking samples which are being sent for cross matching, they are sent in the same EDTA vial, but you have a pink cap for them. That's the color coding. Okay, precisely 2 vials left. One is the green cap vial, which is the heparin vial, and you use it for number 1, osmotic fragility testing, number 2, immunophenotyping, number 3, electrolyte studies. Osmotic fragility, immunophenotyping and electrolyte studies. Coming to the last one, the one that everyone in your family once or twice must have got their sugar testing done. So blood sugar levels are collected in a grey cap vial, and that contains sodium fluoride. Can we do a very quick recap? If you get red and yellow, you want the blood to clot, so you do for serum studies. For lavender, it is EDTA, you're using it for CBC, PS and Wintrob of ESR. Instead of the same EDTA vial, but you change the cap to pink, it is used for cross matching. If you want to measure ESR by Westergren's method or do coag studies, it is light blue vial, citrate vial. If you want to measure the ESR by means of automated machines, you have black cap vial. This also has citrate only. If you want to do sugar testing, you do it in a grey cap vial which has sodium fluoride. Lastly, if you want to test for osmotic fragility, immunophenotyping or electrolyte studies, you have the green cap vial. I hope that is clear to everyone. The next set of images, we have to do blood banking bags. So number one in front of you. Can you see this? Can you see you have these 4 bags? The bag which has the needle attached to it is called the mother bag, because this is the bag in which you have taken the blood donation. This is the bag in which you have collected the blood from the donor. Okay, but now this was whole blood, this is whole blood. You want little components out of it. You want packed red blood cells in one, you want platelets in one, you want plasma in the other. So you want to separate it into components. So these other bags are known as daughter bags, and this is a component preparation bag. So you have one bag in which you've taken blood from a donor, and then you divide it into components: red blood cells, plasma, platelets, and separate ones. In this video only we've discussed the shelf life, we've discussed the temperature. So I hope all of you remember. Now look at the same bag, and now look at the size of what I've done. I've got the same needle. Okay, I've got the same needle, and I've got a mother bag, that's the mother bag, but now I have 4 very tiny kids attached to it, 4 very tiny bags attached to it. See, in the previous one I had 3 bags attached and they were all of the same size. Now I've got 4 bags attached and they're very tiny because they are penta bags. Because these are the bags you're using when you want to give blood to a child, a pediatric blood transfusion. You're not going to give the child 350 or 450 ml of blood. You might have a newborn child, you might want to give only 120 ml of blood. So you're not going to waste an entire bag by opening 450 ml. No, you are going to give the child the adequate amount needed. So remember, these tiny bags are the penta bags which you use for pediatric blood transfusion. The machine that we are expecting this time in your paper, the apheresis machine, use it for platelet apheresis. Earlier it was very famous in your paper for platelet apheresis because, you know, for dengue and for ITP cases they were giving. But now with COVID coming up, the news and the hue and cry about plasma apheresis is a lot, very important. So this is a general apheresis machine, and this is the unit of apheresis. You can see bags which are hanging over here. So yes, we have plasma apheresis also that can be done. This is an apheresis machine. Last one, what is this? This is a platelet agitator. In this you keep the platelet bags. Remember I told you what was the temperature at which you have to keep a platelet bag? 20 to 24 degrees Celsius, and I told you have to constantly keep it in an agitator. It should keep moving, otherwise the platelets will aggregate. I hope that is clear. Okay, what are we left last? Few microbiology images and we are done. Let's begin with first one. This is something you should expect. Please remember, Kirby-Boyer disc diffusion test. This is something you do on which agar? The Muller-Hinton agar. And what is the use of it? Whenever you want to test for antibiotic sensitivity. So if you see this clearing, this means the antibiotic sensitivity is there. These white color discs, they have antibiotics. So if you see the organism being cleared off around it, means antibiotic is working. Okay, if you see it working, you will see a zone of inhibition around it. If you don't see any clearing around it, this means the bacteria is resistant to this antibiotic. So this is the Kirby-Boyer disc diffusion method. It is antibiotic sensitivity testing is the use. The agar that you use is the Muller-Hinton. There's another method of antibiotic testing which you call as the E test or the epsilometer test. How will you pick it up? Look at the strip. The strip will have E written on it. And do you see this semi-lunar, this kind of an arc that is formed? That is also clearing around it. So this also tells you the antibiotic sensitivity. Okay, having done these, let's go on to the eggs. Number 1, we come to the family of cystodes. How do I pick up a cystode egg? How will I pick up a cystode egg? So please remember, for picking up a cystode egg, the first thing that you are going to look out for is going to be a hexacanth. Why do I call it hexacanth? You will see 6 hooklets. So when I say cystode or tinea egg, you will see 3 pairs or 6 hooklets. In the same cystode egg, if you start seeing these polar knobs, if I can zoom in and show you, yes, can you appreciate there are these 2 knob-like projections? If you start seeing these polar knobs, then you are dealing with a case of H. nana. So you have the same hexacanth, but now you also have polar knobs. And do you see some dirty material over here? This is the yolk granule. So this is H. nana. How is it different from H. diminuta? Remember, H. diminuta, you don't see those polar knobs. There are no knobs and this area is completely empty. It looks clear. This is no dirty granules. No granules are seen, means H. diminuta. So the cystode eggs are identified by hexacanth. You will first see, every time you will see hooklets, 6 hooklets. If you see knobs and yolk granules, it is H nana. If you don't see knobs and you don't see yolk granules, it is H diminuta. Coming to the next one, which are the eggs which are going to show you a lid? Which are the eggs which show you a lid? They are the operculated eggs, and the mnemonic is STD. Which are the eggs which show you operculated eggs? Which are the organisms that show you operculated eggs? Spirometra. Trematodes except schistosoma and Diphyllobothrium latum. Spirometra, trematodes except schistosoma and Diphyllobothrium latum. So why not schistosoma? Because S for S. Schistosoma shows you spinous eggs. Schistosoma will show you these spines, okay? And what are the three schistosoma species? Schistosoma hematobium, Schistosoma mansoni, and Schistosoma japonicum. Out of all of these, which has a T? Hematobium, mansoni, or japonicum? Hematobium has a T. Hematobium has a T. So terminal spine. Can everyone appreciate this terminal spine? Terminal spine is seen in Schistosoma hematobium. Mansoni has a lateral spine, and in japonicum you practically don't see one because it has a rudimentary spine. Yes, so remember, all the trematodes have operculated eggs, but schistosoma, S for S, has a spinous egg. So terminal spine in hematobium, mansoni has a lateral spine, and rudimentary in japonicum. Coming to the next one, ascaris or roundworm. They ask you to differentiate between the fertilized and the unfertilized eggs. So please remember, when you're dealing with the fertilized eggs are going to have a very thick albumin coat around it, as you can see, whereas unfertilized egg, you don't see that albumin coat around it. Number one. In fertilized egg, can you see over here, there is a crescentric space out here and there's a crescentric space out here? Yes. In unfertilized eggs, you don't see that crescentric space. So please remember, the fertilized egg is going to be very thick albumin coat and is going to have a crescentric space, that is ascaris. The all-time expected question, the barrel-shaped eggs, the all-time expected question, barrel-shaped eggs with mucus plugs, barrel-shaped eggs with mucus plugs. All of these are the eggs of Trichuris trichura. All of these are the eggs of Trichuris trichura. I hope that is sorted with everyone, no confusion. Okay, last two eggs. Number one, what do you see over here? Do you all appreciate there is a plano-convex egg? There is a plano-convex egg, right? So plano-convex egg, number one. And do you see something inside it? Do all of you see there is a larva-like structure inside it over here? There's a larva-like structure inside it. You call it the tadpole larva. So please remember, plano-convex egg with a tadpole larva. You see another one over here. These are also plano-convex. Plano-convex with tadpole larva is Enterobius vermicularis. Yes? Okay. Coming to the last one. It's an oval egg. And it is going to show you, that's Ankylostoma duodenale, the hookworm. And apart from being oval, it is going to show you segments. This is a segmented ova. So roughly over here, I can see 1, 2, 3, 4. I can see 4 segments. So this is a segmented ova with blastomeres. So that's Ankylostoma duodenale. Quick revision. When you see hexacanth, it is cystode. If you see polar knobs, it is H nana. If you see no polar knobs, no granules, diminuta. If you see operculated lid eggs, STD, spirometra, trematodes except schistosoma and Diphyllobothrium latum. Schistosoma shows you spinous eggs. Hematobium, T, terminal. Mansoni, lateral. Rudimentary, japonicum. Fertilized ascaris, roundworm, thick coat with crescentric shapes. Unfertilized doesn't. Classical barrel-shaped eggs, matlab we are talking about Trichuris trichura. Plano-convex eggs with a tadpole larva, Enterobius vermicularis. Oval-shaped eggs with segmented blastomeres, we are talking about Ankylostoma duodenale. Last question. Which are the eggs which are going to be non-stained? Bile non-stained, Neha. Nectar americanus, Enterobius vermicularis, H nana, and Ankylostoma. Which are the ones which are going to not float on a saturated salt solution? Which are the ones that do not float on a saturated salt solution? Luto, alto, whatever you want to remember. So remember, it is the unfertilized ascaris, larva strongyloids, tinea eggs, and the operculated eggs which we studied for trematodes. Okay, luto or alto. Moving on, coming on to auto-infection. Which is the one that is going to show you auto-infection? Chest. That's your mnemonic. The mnemonic is chest. Remember Cryptosporidium, H nana, Cryptosporidium. H. nana, then you have enterobius, you have strongyloids, and you have tinea solium. So remember cryptosporidium, H. nana, enterobius, strongyloids, and tinea solium. These three mnemonics. For bile non-stained, you have neha. For the ones that don't float on saturated salt solution, luto, alto, and you have chest for auto infection. I hope this is clear with each one of you, because with this we have also finished our target, the final run that I wanted to put up in front of you before the exam. I just want to end by wishing all of you all the very, very best. So all best wishes from my side, and hoping that now when tomorrow when you get back, you tell me that the paper went well or the paper went very well, and we are not going with any negative thoughts on that. So I hope all of you are going to give me a very, very positive result. Really, really waiting for that. Okay, so yes, take a good night's sleep, have a good meal before the exam, go with a positive attitude. In that break between paper 1 and paper 2, please do not chit chat, but do not talk about paper 1. That is really demotivating and can really affect your performance in paper 2. So yes, maintain your social distancing, keep all safety, keep all precautions while you travel till your center, stay well hydrated, and wishing you all the very, very best once again. Thank you so much. It was indeed a very good journey with all of you in the past 10 days over the Unacademy platform. I hope me, myself, and all the other educators, we've been able to, help you in the best possible way, and we sincerely do hope that it works wonders for all of you guys. Wishing you all the very, very best. Take care.